All right, so today I'm going to take you through chronic liver diseases that we commonly see. This is going to be adult hepatology. I'm not going to talk about childhood diseases, which also number several different conditions, including cystic fibrosis, although we do see those adults these days, and some of the other pediatric conditions. But this will be confined to the big five. That we viral hepatitis, fatty liver, iron overload, copper overload, autoimmune hepatitis, and a couple of others. All right, so the most important thing I want you to take away from this is do not order these hepatitis panels that I see on the lab, where you can order acute and chronic viral hepatitis things. They're always inaccurate for what you're actually looking for. And I want you to remember to order what you need individually and utilize biochemical injury patterns, the absolute values of the enzymes that we're going to talk about, and things will just fit into place much easier when you do that, and you can come to a very easy diagnosis in many cases. All right, so when to suspect something is chronic in terms of liver disease. We really define that as elevated liver tests, and that's usually the aminotransferases, ALT, or in some cases, the cholestatic enzymes, alkaline phosphatase, that are present for several months, usually more than 6 months. And obviously, if you have chronic viral hepatitis, we're talking about hepatitis B and hepatitis C. The others really are not chronic, and they would be present for more than 6 months as well. All chronic liver disease obviously can start out as acute liver injury, and that includes drug-induced liver injury in some cases, but going by these persistent elevations for more than 6 months is a good thing to think about. Acute hepatitis may complicate chronic disorders, or what we call acute on chronic liver injury. We see this sometimes in cirrhotic patients, for example, where there's acute alcoholic hepatitis on top of chronic alcoholic cirrhosis. The injury can be hepatocellular or cholestatic, which we'll go through, and the patient may not have any symptoms. All right, so talking about what is considered chronic, I love Gary Larson, so, we give names to dogs. This is our dog Rex, okay? But the names they give themselves are quite interesting. And so we'll go through a number of the chronic liver diseases that we deal with on a regular basis. It's interesting that when patients think of cirrhosis, they think almost always of just alcoholism. They don't think about any of the other causes. So lots of patients, when they're referred for cirrhosis, say, well, I never drank. I don't drink now. How could I have cirrhosis? And we'll go through that. So obviously, there's a lot of different etiologies for chronic liver disease. And as I said, we're going to talk about the big five, and maybe we'll have time for the cholestatic injuries. So just in terms of how high liver tests go in chronic liver disease, for the most part, chronic viral hepatitis B or C, and even Delta, fatty liver disease, and the other metabolic liver diseases, Wilson disease, hemochromatosis, alpha-1 antitrypsin deficiency, the values are generally below 5 times the upper limit of normal. And you have to also remember that the labs are getting the message that they've always had an upper limit of normal that's probably too high. LabCorp used to be 40. I think they've reduced it down to around 32 or 33 now, which is more accurate. The one exception is autoimmune hepatitis, where you may see elevations that persist at very high levels, 10 times or higher. We're talking ALT in the 300s, 400s. And NASH can rarely do that. Mostly NASH is below 5 times normal, but occasionally we see people people who walk around with an ALT of 300, 400 sometimes. With alkaline phosphatase, the chronic cholestatic conditions are primary biliary cholangitis and primary sclerosing cholangitis, and they're usually low, below 5 times the upper limit of normal. Sarcoidosis is the one that's interesting, which can be very high. It's not uncommon to see an alkaline phosphatase approaching 1,000 for sarcoidosis. As a chronic liver disease. Of course, if you have acute bile duct obstruction, pancreatic cancer causing obstruction, you may have alkaline phosphatase that's quite high, but it wouldn't be considered a chronic liver disease in that sense. And then obviously bilirubin is variable. Remember, Gilbert syndrome is present in 5 to 10% of the normal population. But its cutoff is an indirect hyperbilirubinemia that's less than 5 times the upper limit of normal. If it's beyond that, something else is going on. Now, the biochemical clues to who has fibrosis, who has cirrhosis, these are some very simple things that we do in the clinic all the time. You look at the ratio of AST to ALT. If the AST is higher, you automatically think of alcohol. You should think of muscle injury. You should think of ischemic injury if the values are very high, but that's usually an acute injury. So is muscle injury, should be acute rather than chronic. You look at the globulins. If they're higher than albumin, that's also something we see in cirrhosis or chronic liver disease. A platelet count below 140 could be cirrhosis. An INR above 1.3, if you're not on Coumadin, etc., means some form of hepatic impairment. You can do something with your calculator called a FIB-4 score, a fibrosis 4 score, which is based on your age, your AST, a platelet count, and the ALT. And all of the calculators have this. You can just plug it in, and it gives you a fibrosis score, as you can see here. And in the clinic, we can do a FibroScan, and we get a fibrosis score, or what's called an E-score. And if it's above 12, that usually means advanced fibrosis and possibly cirrhosis. Physical findings, I like to say that there's at least six or seven clinical findings of cirrhosis by just looking at somebody's hands and their fingers. You can see spider nevi if they have clubbing, Dupuytren's contractures, palmar erythema, muscle wasting, enlarged lunules, which usually mean hypoalbuminemia. You can see the flapping tremor, asterixis. You can see ecchymosis. So look at their hands, very important, and you may pick up cirrhosis. Why is recognizing cirrhosis important? Well, if we have a patient with cirrhosis, no matter what the cause, we need to screen them for hepatocellular carcinoma. And the screening, as you all know, is you can start with an ultrasound. And if you don't see any focal lesions or suspicious lesions in the liver, you can continue with ultrasounds every 6 months. We don't do ultrasounds every year because you could miss a large tumor that starts at the end of 6 months and gets too big to do anything with by the end of 12 months. So we have to tell our patients they have to come in every 6 months. If they have cirrhosis, we need to screen them for esophageal varices. They may need beta blocker therapy at that point. If they have cirrhosis, we sit down with the patients. We tell them what are the warning signs of decompensation. If they develop ascites or GI bleeding, encephalopathy, etc. And then obviously there are drug-drug interactions and differences in drug metabolism and pharmacokinetics that affect many of the drugs that cirrhotic patients may take, and we need to understand those. And obviously the most important is if they have advanced fibrosis, early cirrhosis enough that they've got a MELD score above 15 or so, we should consider transplant evaluation or referral depending on which hospital you are. The biochemical injury patterns are also important. Hepatocellular injury is defined by an elevation in ALT or AST. And if I already mentioned that if your AST is higher, it's alcohol, muscle injury, cirrhosis, ischemia, etc. There's also something called macro AST, where the AST is an isolated finding, it's elevated, everything else is normal. And it may be this peculiar benign condition. When the ALT is higher in a chronic liver disease, it means a non-cirrhotic condition, and it could be anything that's listed here. The cholestatic injury is defined by an elevation in alkaline phosphatase. The aminotransferases should be normal or just minimally elevated. And obviously, a cholestatic injury from chronic liver disease are all the ones that are listed here: PSC, PBC, sarcoid, lymphoma, other things. Notice that bilirubin does not appear on this slide. You can't differentiate hepatocellular from cholestatic injury by bilirubin alone. Even if somebody comes in deeply jaundiced, you have to determine if it's due to alkaline phosphatase elevation or aminotransferase elevation, or something in the middle, which would be mixed injury. And then we can call it hepatocellular jaundice or cholestatic jaundice. And simply having jaundice doesn't mean liver failure. Liver failure, as you all know, means the abrupt onset of encephalopathy and coagulopathy. It has nothing to do with the height of the liver tests or bilirubin. These are our definitions. We'll start with hepatitis B. I'm going to be very quick through this. You have all the slides, so I'm not going to spend much time on hepatitis B. Obviously, we see it a lot. These are patients you have to remember to screen them every 6 months for liver cancer, whether they have cirrhosis or not. We're seeing more and more liver cancer in non-cirrhotic hepatitis B patients as they get older. And being on antiviral therapy reduces the risks considerably, but it doesn't eliminate it. The difference between acute disease and chronic disease, obviously, if you have acute hepatitis as an adult, you're going to have surface antigen, E antigen, DNA goes up abruptly, and then if you are able to clear the infection, which happens in at least 99% of adults who are infected with acute hepatitis B, the core antibody, which is which we use to diagnose hepatitis B as an acute infection with the IgM fraction, it disappears and is replaced by the IgG fraction. For patients with chronic disease, they continue to have surface antigen. They may or may not have E antigen, and we'll go through that. That's an important group to understand. They will all have core antibody, but it'll be IgG at that time. And they may or may not have elevations in ALT, but they will have elevations in their viral load. The progression of hepatitis B, you can read it here. The incidence of developing cirrhosis, if you've got E antigen positive, it's actually a lower incidence of cirrhosis than if you're one of the E antigen negative mutations. These are the pre-core or core promoter mutations, which we can actually test for. So there's an incidence of cirrhosis. Obviously, there's an incidence of HCC. It's higher with cirrhosis. And then it depends on a number of other factors. We don't really do a lot of genotyping for hepatitis B. It is possible to do it, but the Asian genotype, which is B and C, probably have a higher incidence of liver cancer associated with them. There are 4 phases of chronic hepatitis B, and these, I'm going to spend a minute on these because they're important to distinguish between them. What we call immune tolerance, immune clearance, which is really the chronic active state of hepatitis B, where your immune system is kicked in and is trying to get rid of the virus, and your enzymes go up. You may have symptoms. The chronic carrier state, which is just surface antigen is positive. And we don't need to treat that group, but we need to monitor them. And then obviously there's a reactivation phase. Some of those people have e-antigen negative chronic hepatitis B, and we need to distinguish them from the chronic carriers who are also e-antigen negative. And I'll let you, at your leisure, go through these, the rest of these slides. But the immune tolerant group have the highest level of virus. They can have viral levels in the billions with a B. No one else has high levels like that. They're all e-antigen positive. Their ALT is normal. Their liver biopsy will be normal. They have no symptoms, and they can persist in the immune tolerant phase for decades. Now, these are almost exclusively individuals who've been infected from birth, and they can be in the first several decades with these high levels of virus. And our current treatment recommendations are to monitor them. The only ones who really get treated are if their enzymes start to rise, if they have a strong family history of liver cancer. We would consider putting them on treatment, but we do not think that the treatment is as effective as it is in other groups. The immune active, this is the e-antigen positive group, which means this is a wild type, non-mutated virus. And their enzymes are often elevated. There's obviously inflammation on biopsy. Their viral load is typically elevated, can be in more than 10,000, usually less than we see with the immune tolerant group, which can be extremely high. And these are patients who are good candidates and need to be treated. And what we look for is a reversal of that e-antigen positivity. If we can seroconvert them, then they go into the inactive carrier state, which is the next one over. These are patients with very low level viral loads, normal ALT, e-antigen is negative, and we follow them. But we have to distinguish them from the e-antigen negative chronic hepatitis patient where their viral load is higher. These are patients who can't make e-antigen because they have the mutation. Their ALTs often are normal or fluctuating. Their viral load can fluctuate. If you did a biopsy, there would be inflammation, and we put them on treatment. And just to, again, to drive the point home, they're both surface antigen positive. They may both have normal enzymes, but the HBV DNA, the viral load, is high in the chronic hepatitis B e-antigen negative group. And we can test for the pre-core mutation. If they have it, we treat these patients. This was a study done in Taiwan. It's called the REVEAL study. It'll never be repeated because they watched patients who had hepatitis B on no treatment. They didn't have any therapy at the time. And what this slide showed is that both the development of cirrhosis in green and the development of hepatocellular carcinoma in red is directly related to the height of the viral load. And that's why treating these patients, we can bring their viral loads down to undetectable levels, but we don't cure the disease. And the reason we don't cure it is that the virus is still replicating in the nucleus. Hepatitis C we cured because it was replicating in the cytoplasm and we could get to it, but we can't get to the CCC, or closed circular covalent DNA, in the nucleus of these patients. There's several drugs that are under study to try to do that, but right now we put these people on the antivirals that we have, the tenafavirs, the entecavirs, and we can drop their levels down to undetectable, which also reduces their risk of progression and their risk of liver cancer, but we still have to screen. And that's what this says. And when do you start screening? I start screening them as soon as I see them as an adult. The old guidelines said you didn't have to screen before age 40 or 50. I think that's much too old. I just start screening them when I see them. And there's actually literature that says you might start at age 20, especially if they have cirrhosis. or with a family history of liver cancer. Alpha-fetoprotein testing is an adjunctive therapy. Don't use it, don't rely on it by itself, because a third of liver cancer patients have normal values. The two first-line agents or three first-line agents are in red, and this is what we rely on to treat them. Hepatitis C, we used to see lots of it, and we've treated so many people now that we're hardly seeing these patients walk through the door anymore, but it's very important to continue to screen. And you know, they've expanded the screening now. It used to be just the birth cohort if you were born after World War II, but now it's anybody over the age of 18 if they've got risk factors for hepatitis C, transmission, transfusions, IV drug use, multiple sexual partners, for example. A negative hepatitis C antibody does not exclude acute hepatitis C. It's one of those things on the panel that if somebody comes in with high ALT and you do a liver hepatitis panel and it says negative hepatitis C, that's the antibody. That does not exclude an acute infection because the antibody remains negative for weeks to months. And the only way to diagnose acute hepatitis C is with a viral load. So just, again, another reason not to do those panel tests. But this, for chronic disease, it becomes chronic in 80 to 85% of adults, less than 50% in children, and it may disappear spontaneously. There are a number of different extrahepatic manifestations associated with hepatitis C. The ones that we see predominantly are cryoglobulinemia. All those patients should be tested for hepatitis C. And we're on the east, you know, we live in the Chesapeake Bay area. We see a lot of watermen who come in with porphyria cutanea tarda. You can look at the back of their hands, it's all scarred, they may be blistered. You ask them questions, yeah, it gets much worse when I'm out in the sun, that kind of thing. All of those patients should be tested for hepatitis C because many of them are infected and it's a manifestation. The treatment, as you can see here, it's an older slide, but now we're approaching 100% cure rates with our direct-acting antiviral agents, and it's a true cure as opposed to the hepatitis B. All of these patients with hepatitis, if they have chronic disease, should be vaccinated for everything else that you can think of, including flu shots every year. Those with hepatitis B or C should be checked for hepatitis A immunity and vaccinated. Because if you get an acute hepatitis and you already have chronic hepatitis, you tend to do poorly. Again, if they've got cirrhosis, they need to be screened. How much alcohol can patients drink if they've got chronic hepatitis? Well, I say it's too much if they have to ask you, if it's more than you drink, and if they don't think beer and wine counts as alcohol. If they only think hard liquor is alcohol, then tell them no alcohol. Nobody listens, but some of them actually will reduce it. And with fatty liver, for example, there's good information now that any amount of alcohol, even a little, is harmful. And it's a useless carbohydrate. It's an empty calorie that they don't need. And so many of our NASH patients will cut back on their alcohol. And that brings us to NASH. So what are the definitions? We've got NAFLD for non-alcoholic fatty liver disease, which is the entire spectrum. We've got NAFL, which is really just isolated hepatic steatosis without enzyme elevations, which suggests that they do not have steatohepatitis. NASH is the steatohepatitis component, which really requires a liver biopsy to show the fat and what we call hepatocyte injury or ballooning degeneration. with or without fibrosis. We now have a number of non-invasive measures that we use clinically in clinical trials, and there's probably 20 clinical trials going on, 20 different medicines to treat NASH, and they require liver biopsy because they're only, the endpoint for the FDA is reversal of the NASH and the fibrosis. And so they need liver biopsies, but for the patients we see in the clinic, we generally do not need a biopsy. It's become the most common liver disease on the planet, in the US anyway, and slowly overtaking viral hepatitis in many Western countries as well. Hepatitis B, Hepatitis C still lead the list, but with vaccinations for B and others, we're seeing less. You can see the prevalence here of fatty liver disease. And when we say non-alcoholic, we usually mean low alcohol consumption, although that's why the name is probably going to be changed to metabolic associated fatty liver disease, or MAFLD, in the future, because it's really about the metabolic syndrome that these patients have. And there are many different components of that. Most of it is diabetes and obesity. Obviously, many of these patients are also they're hyperlipidemic, they have hypertension, they may have obstructive sleep apnea, they may have PCOS, polycystic ovaries. And so these are the things that we look for in all the patients who come in with mildly elevated liver tests. Those are the, they walk in the room, their BMI is 40, they're diabetic, and, NASH is the first thing that you should be thinking of. The clinical features are listed here. We may or may not see any of these. The enzymes I've already mentioned are usually less than 5 times ALT, but can be quite high. The alkaline phosphatase is usually low or normal. Very importantly, they can have other biochemical features. Ferritin is commonly seen as an elevation in NASH patients, and it does not reflect iron overload in the vast majority. And then very importantly, a positive anti-nuclear or smooth muscle antibody in low titer is seen in up to 40% of patients with fatty liver disease. And so the differential gets expanded. Well, maybe they have got autoimmune hepatitis and not just fatty liver. And this is where we would often do a liver biopsy if we can't tell. But there are other features of autoimmune hepatitis that I'll go over with you. And in many instances, we don't need a liver biopsy, because sometimes these autoantibodies are fleeting. They disappear if you repeat them. That doesn't happen in real autoimmune hepatitis. So diagnosing NASH, you can see it on an ultrasound, a CT scan, an MRI. In fact, MRIs with the percentage of fat is now part of FDA trials. In our liver clinic, we do a fibroscan, and in addition to giving us a CAP score, which is the proportion of fatty hepatocytes, and if you have a CAP score above 250, it means that there's significant fat in the liver. That's an easy one, non-invasive. We can do that point of service in many instances. You can also do one of the blood tests that called a FibroSure or FibroSpect, which are specific for NASH, although they're all algorithms based on procollagen 3. Not as accurate as a FibroScan. Biopsies are done, but less and less these days. And the ALT should be higher than the AST in NASH that is not cirrhosis. Very important. If they have NASH cirrhosis, you'll see an AST that becomes higher than the ALT, as it does with progression from any chronic liver disease to cirrhosis. Let's turn to alcohol. There's many different forms of alcoholic liver disease, and not everything is alcoholic hepatitis. That's very specific. Alcoholic steatosis is simply having fatty liver from alcohol. And generally their liver tests may be mildly elevated. They don't have symptoms, they're non-cirrhotic. Alcoholic hepatitis is very specific. This is the acute onset of jaundice, right upper quadrant pain, leukocytosis. Their enzymes will be elevated. And it's a very serious condition. We hospitalize those patients. Alcoholic cirrhosis, they can walk around with that for years, but they're always subject to acute on chronic liver injury. They may get acute alcoholic hepatitis. They go out and binge on top of their cirrhosis. And as I said, the ratios for alcohol are very important. The AST is almost never greater than 300. The ALT is almost never greater than 100, even in serious cases of alcoholic hepatitis, where the patient, may go into liver failure. When they go into liver failure, their enzymes may skyrocket because of ischemia. But if you look, when they first come to the hospital, their enzymes, as sick as they are, will usually follow these absolute values. It's the only liver disease that has an upper limit for their threshold. GGT goes up in alcohol because it's an enzyme. It's induced by alcohol. And we can sometimes follow GGT to see if somebody has stopped drinking. If their GGT is high, and it's way out of proportion to alkaline phosphatase in alcoholic liver disease. The GGT may be 1,000. Then they tell you they stopped drinking and it'll come down. It takes weeks to months for that to happen. These are, I don't have a pointer here, I don't think, unless you can see this one, but these are Mallory bodies. And Mallory's hyaline is something that we would see all the time on liver biopsies in alcoholic patients. And this was in the right history. This was alcoholic hepatitis, and this person presents with fever, leukocytosis, right upper quadrant pain, tender hepatomegaly. The ratio is right for ALT, AST. Bilirubin was high, white count for leukocytosis. This is alcoholic hepatitis. All right, let's move on to some of the other chronic metabolic diseases that affect the liver. Let's start with iron overload. This is a Prussian blue stain of iron. Everything that turns blue is iron. And this is somebody with wide bands of fibrosis. This is cirrhosis. These are nodules in somebody who presents with diabetes and cardiomyopathy, ferritin 4,000. It's hemochromatosis. It's the most common autosomal recessive disorder. The gene frequency is listed here. It's highest in Northern Europeans, which is when people come in and they've got a high ferritin. I always ask them, where's your family heritage from? And when they tell me it's Scotland or it's Scandinavia or someplace like that, there's a very good likelihood that they could have iron overload. It leads to iron deposition in several other organs, as you can see here. And the classic genetic hemochromatosis is present in over 90%, but there are other forms of inherited iron overload, which I've listed here, which we can test for, not easily though. They're not routine tests, but not everything is the classic C282Y or the H63D gene mutations. These are the most common missense mutations on the HFE gene. And you can see, you can also be what we call a compound heterozygote, meaning you've got one 282 and you've got 163 allele, and those patients are as close as you can get to homozygous C282Y patients. The heterozygotes for C282Y, meaning they've got one gene and the other is normal, are usually unaffected patients. And the C6 and the 63D heterozygotes also usually unaffected. We don't have to treat them because usually they never develop disease. Symptoms of hemochromatosis, they're nonspecific. Fatigue, right upper quadrant pain. We see that with viral hepatitis. We see that with fatty liver, arthralgias. We see that with autoimmune hepatitis. The impotence, decreased libido, that could be hemochromatosis. Obviously, diabetes, heart failure due to cardiomyopathy, testicular atrophy, the bronzing of the skin. It was, in your old times, it was called the bronze diabetes condition. All of these could be clues that hemochromatosis is present. Symptoms usually appear in middle age, but only 10% of homozygous C282Y patients actually develop significant liver disease. So there's a very high degree of incomplete penetrance. So even if they're homozygous, doesn't mean they're going to be sick, and it doesn't mean we're going to have to treat them. But HCC is something that we're seeing more and more of in hemochromatosis. And if you've got cirrhosis already, you've got one of the highest risks of liver cancer from hemochromatosis. Over 3/4 of these patients are diagnosed simply by routine screening, having a high ferritin, and you get worked up. The HFE gene mutations, are, as I said, are only seen in about 93%. The other 7% have those other conditions. Liver biopsy used to be mandatory, but we don't have to do it as much anymore. If it's obvious to you that you've got a homozygote or a compound heterozygote with a ferritin that's on the lower side and normal liver tests, that person has hemochromatosis. We're going to simply start treatment, which is phlebotomy. If their ferritin is very high and you need to rule out cirrhosis and you can't do it non-invasively, then a liver biopsy is important, because if they have cirrhosis, then you have to start screening for liver cancer. Family screening is something that we should all be doing as well. And ferritin and iron saturation recommended in all first-degree relatives with hemochromatosis who are undergoing treatment or you're considering treatment. But the heterozygotes who are not at risk, if they're a relative, in the absence of other diseases, may not need to be screened. So if you don't think that they have some other chronic liver disease, then you don't really have to worry about hemochromatosis, but it's easy enough to do. For children, if you've got someone who is positive, you check the parents, because you need both parents to be positive for the child to be affected. So if one parent is not affected at all, then the child doesn't need to be screened because they're not going to have significant risks. The treatment is phlebotomy. How often do you do it? You send them to hematology, and they go to the transfusion center, and they'll do weekly phlebotomy if the patient can tolerate it. And what we're looking for is get that ferritin down to below 50, certainly less than 100. And you want their transferrin saturation below 50 as well. And then once you've got them there, you do a maintenance phlebotomy every 3 to 6 months. I've got some patients who just do it once a year and they're fine. Iron chelators, not very effective. We use them for other conditions. But it takes a long time for those chelators to work. The prognosis, normal life expectancy if you're not cirrhotic. The manifestations of hemochromatosis that improve with treatment. These are boards questions. The cardiomyopathy, pre-cirrhotic liver disease, and diabetes can all improve with phlebotomy. The manifestations that fail to improve is the arthritis, the pseudo-gout, testicular atrophy, and if you've already got established cirrhosis, probably not going to improve. And as you can see here, the risk of liver cancer is 200-fold elevated in hemochromatosis with cirrhosis. And if you've got cirrhosis, just like any other cirrhotic, you're at increased risk of all these other infections. We tell people not to eat raw oysters, raw shellfish, because of the Vibrio possibilities. So we live by the Chesapeake Bay. Everybody eats raw oysters. We have to tell them not to. All right, this is a copper stain. Everything that you see that looks tan is copper. And this is also cirrhosis. You've got, these are nodules here. This is a woman who presents with dysarthria and hemolytic anemia, low ceruloplasmin. And obviously you'd have to think of Wilson's disease. This is another autosomal recessive disorder. The main mutation is this ATP7B on chromosome 13. And they're now trying gene therapy to correct this defect. The prevalence is low, as you can see here, but both genders, all races equally affected, and the copper accumulates in various tissues, including the liver and also the brain, also in the kidney, renal tubules. And that accounts for the manifestations that we see. I won't go through the copper metabolism. You can read through this, but we do put people on low copper diets, which means, you know, fewer nuts and other things. I'll go over those with you. When to think of Wilson's disease: unexplained acute liver failure. Some of these patients present with acute Wilson's disease, or they present with unexplained chronic hepatitis or cirrhosis in a very young individual. And Wilson's disease is not diagnosed after the age of 55. So save your money on ceruloplasmin for the 80-year-old patient who comes in with elevated ALT. It's not going to be Wilson's disease. If they have neuropsychiatric symptoms, Wilson's should also be thought of. If they go to the eye doctor and they've got Kaiser-Fleischer rings or unexplained anemia or renal tubular acidosis from the nephrologist. These are all things that can be Wilson's. Symptoms rarely before the age of 5. They get liver disease early in life. The neuropsychiatric symptoms more commonly in adulthood, rarely presents after age 40, as I said. The Kaiser-Fleischer rings, composed of these copper and sulfur-rich granules. They're seen more often in patients with neurologic disease than hepatic disease. And here's some examples of the Kaiser-Fleischer rings. On a slit lamp, they can be seen. They can sometimes be seen in the naked eye, but it often takes an ophthalmologist. So the two presentations, the chronic hepatitis, a urine copper level is part of the diagnosis if it's greater than 100 micrograms in 24 hours. If they've got Kaiser-Fleischer rings, only 50% with the liver disease may have them. And the ceruloplasmin may be normal in some of these patients. They also may present as fulminant hepatitis, and this is the board's question with the lowest level of alkaline phosphatase you'll ever see. It's, you know, it can be 10. It's mostly young people with an associated hemolytic anemia and other features. They'll often have Kaiser-Fleischer rings. The neurologic features are listed here, that they may have a tremor, dystonia, dysarthria, and much of that improves when they're treated. The psychiatric manifestations are here. Again, you'd have to think about Wilson's with somebody who's got any kind of neuropsychiatric problem. The renal disease is mentioned here as well. The treatment, the standard treatment used to be D-penicillamine, but it had a lot of side effects, and we don't use that first line anymore. We use trientine, which is a chelator. of copper. We use that in often in a combination with oral zinc. Zinc competes in the intestine for copper absorption. And so it increases the fecal excretion of copper. The low copper diet is shellfish, nuts, chocolate, mushrooms, and of course, liver. And interestingly, liver transplant for these patients is curative. These patients are restored with the normal phenotype of the donor, and they no longer have Wilson's disease. And as I said, they're now working on gene replacement therapy. They're with nanoparticles and things. A number of trials are underway. That's the future. What did I say about monitoring Wilson's disease? Oh, how do we monitor them? We do urinary copper and keep the, we want to keep it low, less than 75. We want to keep their ceruloplasmin normal. If you want to look at that, you want to make sure that they're not anemic, that they're not having renal problems. And I think we've got a few minutes. We'll go over alpha-1 antitrypsin. Again, the most common metabolic disease of children. It's autosomal recessive. All of these are autosomal recessive. There's a higher incidence among Caucasians, and it's associated with COPD. So you've got cirrhosis in a heavy smoker who's also puffing and wheezing. Think alpha-1 antitrypsin deficiency. The biopsy will show diastase resistant PAS positive granules. These little red granules show up on biopsy. It's quite easy to see. The testing for it, we've got genetic testing for it. The homozygous ZZ patients nearly always have disease. The SS patients, again, Northern Europeans, so you're competing with hemochromatosis here. And I think they go together in some cases. They may be affected as well. The SZ mutation, clinically significant in smokers. And for right now, you tell people if they're smoking, stop smoking. Adults develop cirrhosis, which may be part of the cryptogenic cirrhosis, which we've often attributed just to NASH, but anybody who's got fatty liver cirrhosis that's considered cryptogenic, where we can't see the fat anymore, always check for alpha-1 antitrypsin because you may find it. They're at risk of liver cancer as well. Recombinant DNA therapy from pooled plasma is being used in some cases. Stop smoking. Secondhand smoke, also important. Liver transplant corrects the metabolic defect, just like Wilson disease. All right, and then I've got a couple minutes left, I hope. Let me just take you through the last two, or last thing, which is, here's a woman, 24, presents with fever, jaundice. She's got a history of thyroiditis. Somebody called it Hashimoto's. Her enzymes are quite high. Her bilirubin is high. She has a liver biopsy. It's loaded with inflammation, and you may not be able to tell, but these are all plasma cells, all these dark cells in here, many plasma cells, all monocytes and plasma cells. And this would be idiopathic autoimmune hepatitis. And we're seeing more of this in the clinic. It's commonly seen in younger women more than men. It's a bimodal distribution in terms of age. We see young women, we see also older women in their 60s sometimes present with autoimmune hepatitis for the first time. Drugs can sometimes cause autoimmune hepatitis, especially long-term use of nitrofurantoin or methyl-dopa, hydralazine. Rarely statins do this. These are patients who come in, they've got markedly elevated ALT. This is the group where, you know, their ALT is going to be in the several hundreds. 20% present as acute hepatitis. For all the world, you think this is acute viral hepatitis, but it's the first presentation really of autoimmune, and it may be an acute on chronic autoimmune presentation. 40% have other autoimmune disorders, predominantly thyroid disease, Hashimoto's, Graves' disease, very common. There are two major types. Type 1 is adult. They've got anti-nuclear or anti-smooth muscle antibody in most cases, 75% of women, 40% with the other autoimmune disorders. Type 2 is considered the pediatric autoimmune disease, mostly children of European descent. This is where you're going to find an anti-liver kidney microsomal antibody present. They can have diabetes, thyroiditis, vitiligo, and they progress to cirrhosis at a very young age, and are at risk for all kinds of problems as a result. Many end up with early transplants. There are very important overlap syndromes. Somebody comes in with what we think is PBC, but they also have a positive ANA and an AMA. We think that this might be an overlap of the two syndromes, and it's very commonly seen. It can be an overlap of autoimmune cholangitis as well. We've seen it with chronic viral hepatitis and autoimmune hepatitis. But remember, 40% of fatty liver patients have the same autoantibodies, including AMA in some cases. And this is where we might need a liver biopsy to show the features of autoimmune hepatitis rather than just fatty liver alone in order to determine what they have.